You're listening to the Sick and Good podcast. My name is Dustin Messick, RDN. I'm a cancer survivor.
My name is Dr. Colin Goodwin, and I'm a cancer survivor. We're discussing topics related to cancer treatment and recovery while promoting wellness.
To find a balance between sick and good.
That during the cancer process, both can be true.
The Sick and Good podcast is for educational purposes only. The podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition or treatment, and before undertaking a new healthcare regimen.
This is the Sick and Good podcast, and joining us today is Dr. Rhonda Sherman. She's a licensed psychologist in the state of California, as well as Texas, where she is currently in a private practice in the Houston area. Dr. Sherman has been in private practice for the last 19 years, with over 25 years in the field of psycho-oncology. So welcome to the podcast.
Oh, I'm happy to be here.
Can you define psycho-oncology for our listeners? Just wanted to start with that.
Sure. The field of psycho-oncology actually began developing in the mid-1970s. And basically, it's a subspecialty of oncology. And it addresses the psychological, behavioral, emotional, social, spiritual issues that may arise for cancer patients. And also studying and looking at how a individual's psychological states and issues can affect their treatment and their care.
What made you interested in this field?
Well, that's actually an interesting story. Indulge me. I started developing an interest, well, I didn't know it was back then, an interest in psychology at a young age, wondering basically about individual differences sitting across the dinner table. Why does my brother like cauliflower and I don't? And why do some people are shy and quiet and some people are not? So I always was very interested in human beings and individual differences. As I moved along in high school, I became interested in science, and I was a volunteer at our local hospital during high school. I liked being in a hospital. I liked being at the bedside of patients. I loved science class. And so when I went to college, I was in a liberal arts honors program and gave me a lot of flexibility. I found myself gravitating towards psychology and wound up with a couple of majors, one being psychology, and doing some research. So you figure, what do you do with an undergraduate psychology? Do you go to graduate school? And as I went to graduate school, unfortunately, the year before I started, both a friend of mine and my father were diagnosed with cancer. And they both passed away in the fall of 1992 during my second year of graduate school. So then cancer became personal. As I started moving through graduate school, coming upon a dissertation time, I found myself perusing the books in oncology in the library and found one on cancer and sexuality. And it just hit me. This is what I want to look at. And so I wound up completing a dissertation about sexual functioning of bone marrow transplant survivors at Roswell Park Cancer Institute in Buffalo. And then as I continued along, I just gravitated again towards hospitals and did an internship at the VA in Long Beach, working in oncology with HIV. This is in the 90s, chronic pain, cardiac rehab, spinal cord injuries, and found myself answering for a job that was posted at a pain conference at the City of Hope Cancer Center outside of Los Angeles, which I started in 1999, and I haven't stopped since working in oncology and love it. It is where I just need to be, and it's what I do the best as a psychologist and what I know the most about.
Thank you so much for sharing that. I was curious about perhaps the referral process, how clients are referred to you, or perhaps how listeners can find psychologists in their area.
Right. So as a psychologist in private practice, it's really up to us, those of us in private practice, to go and find our referral sources and attempts at marketing. And so I kind of embed myself. My office is located within a hospital system in a medical office building connected to a hospital. And previously, when I practiced in San Diego, the same thing. I found an office on a hospital campus because I wanted to be surrounded by oncologists. I felt like that's where I needed to be. And so I try to meet the oncologists on my campus. And in Houston, we have the Texas Medical Center, and we have plenty of hospitals in the Houston area. And so I will connect with oncologists and directors of oncology programs. And so my refers come straight from the oncology offices. A lot of the oncology nurse navigators and the nurses in the practice. And that's mostly where my referrals come from. In terms of the listeners trying to find a psychologist or mental health provider with oncology experience can be a little challenging. I think the first place to start is our professional organization, the American Psychosocial Oncology Society. And I will give you the website, and maybe you could post it. It's www.apos-society.org. And that is the National Organization for Psycho-Oncologists. And there is also, if there are any international listeners, there is the International Psychosocial Oncology Society. And I would start there to find a therapist or mental health provider. Another place are for listeners to call their local American Cancer Society office.
So just to switch gears a little bit here, I just wanted to ask, what are some of the most common issues that clients present with in their initial appointment?
Oh, so yes, the initial appointment was the key word. I find it very interesting that over the years, patients will be referred to me because they have a cancer diagnosis and they are exhibiting some type of distress, crying, anxiety. Maybe they have voiced some thoughts about harming themselves or refusing treatment. And so they come with basic anxiety, sadness, difficulty coping with cancer treatment, the side effects. There's a lot of what I say to my clients, a lot of loss and change. Cancer is all about loss and change. And maybe the clients have never dealt with loss before, so this is new, but it is a very acute, fast change and loss in their life and loss of their future that they expected to look a certain way. And it may be different because the cancer experience, the cancer diagnosis follows you. But interestingly enough, so that's the initial presentation, and we provide interventions and support and what's needed. But I find that with a large percentage of my clients, it turns into other things, that issues that were really going on with them prior to their cancer diagnosis seem to come up. And it turns in kind of to I'll say regular psychotherapy that some people might come into therapy for. A lot of marital issues, a lot of marital dissatisfaction, a lot of work dissatisfaction. So people wind up sometimes changing relationships, sometimes improving their marriage, sometimes changing jobs and professions. So it's really interesting. It starts with the cancer, and sometimes I wind up seeing clients longer term to address other issues that they never addressed before. So it's really, I consider cancer and any crisis, but specifically cancer, an opportunity, an absolute opportunity for, I always say ... for anything, but for growth and well-being. And a lot of my clients that I work with said that they are happier now since their diagnosis than they were before their diagnosis, because they've addressed these issues that were never addressed before, and now they are.
That's really interesting. You mentioned some of the interventions that you rely on. What are some of the types of interventions that you utilize with these clients?
Again, it depends on what they're presenting with, and also depends on what type of cancer they have and what stage. I forgot to mention that. But if someone comes, there's a lot of anxiety. So we first have to figure out what the anxiety is about. I learned very early on in my work in oncology to not assume that every cancer patient is anxious about dying. I made that big mistake and I will not do it again. It wasn't a huge mistake, but I was. So I don't make that assumption. So I would do an assessment like any other mental health provider, psychologist, to try to understand the anxiety. I work a lot from the cognitive therapy approach, where I help the clients identify what their thoughts are, their thoughts about their diagnosis, their thoughts about treatment, their thoughts about death and dying, sometimes spirituality. And I try to help them identify if those thoughts are helpful or distorted or irrational and learn how to modify them. And in addition to that, for anxiety, we'll do some relaxation exercises, a lot of sleep hygiene. Sleep is a problem for a lot of us now, but especially during cancer treatment, sleep can become a problem. So we work with some sleep interventions. Sometimes there's a need for communication skill building, teaching them how to not only communicate to their providers about what they need or what's important to them, but even more so to their family, their spouse, their children, their sisters, their friends. And then we work on some approaches. If there is some existential anxiety and death anxiety, we discuss those. Or from an existential approach, if they are religious or spiritual, I'll help facilitate their thinking about it. I always tell them I'm not a religious expert, but I could help facilitate their process or thinking about it. So when it comes to depression, some of the same cognitive therapy, labeling feelings. Sometimes clients don't know what the feeling is. And so I'll give them a list. I'll pull out my happy face chart or smiley face chart, or just to label what the feelings are and really process with them about what it's about. And help them learn to, hopefully, my goal is with depression, to maybe help them shift their perspective about cancer, about what's happening to them, about their future. And with the majority of these cancer patients I see, we are able to identify actual gifts, quote unquote, gifts that come from this cancer experience. And I love it when that happens. You just see it on their face and there's relief. And to identify there are some good things that can come out of a very traumatic and experience filled with some physical suffering and emotional suffering, that there are some good things that can come out of it. That's most of what I see. Sometimes we'll bring in a spouse. If a client begins to bring up some relationship issues, I will have the spouse join us and we'll do some work there also.
You'd mentioned a couple different issues that are commonly brought up at that initial appointment, and having marital issues or occupational problems.
Mm-hmm.
I was curious if you'd tell me a little bit about how the psychosocial issues impact cancer care and the cancer experience for patients.
Yes. So I don't even think I could list them all now. It's fascinating to me. For example, we talk about work and jobs. What I see a lot in the younger clients with breast cancer, I see a lot of those clients. They're usually very bright, very hardworking, very driven, responsible women. And many of them are mothers, some with small children, some with high school to young adult children. And these hardworking, driven, bright, capable women, sometimes the experience is harder for them because they feel like they have to continue in that same driven, successful path. And they don't take the time for themselves to do the self-care, to take the time off of work if they're able to financially. They want to go, I'm working with some now, they want to go right back into work after some time off, a couple months off, and they go back full time. And I always suggest, if possible, have a slow entry back to work. Maybe go in 4 hours a day, twice a week, then 4 times a week, half a day. And maybe the third week go in full time, 3 days a week, and slowly back in. And you won't be surprised they don't listen because of their mindset. And so that can have a great impact on their recovery and their emotional well-being if they feel like they have to perform at the level they've always performed at. So that I find very interesting. Compliance to treatment, to oncology treatment. If someone is very depressed or very anxious and fearful of chemotherapy, of needles, it very well may impact their compliance. They may cancel appointments, cancel surgeries, be so fearful of needles or so fearful of chemotherapy that they're vomiting before they get there and they're highly distressed, and then they don't get their chemotherapy that day. So also, I find that some clients that are highly distressed and we haven't been able to lower that distress level can sometimes exacerbate the physical side effects they may be going through. And so then you get a lot of calls into the oncologist and complaints of pain and nausea, and it's all very real side effects, but I find sometimes it's correlated with high levels of distress. So the physicians and I have to work from both ends. They need to work with treating the side effects with their medical interventions, and I work on trying to treat the distress. And sometimes we call in psychiatry, or I refer to psychiatry for some psych medication that may help with their distress. If an individual, a cancer patient, does not have good communication skills, that may lead to not receiving the best care for themselves. I really want cancer patients to have a good relationship with their providers and feel safe and feel they could trust. And if someone is not used to being assertive or speaking up about their needs, not only do they might not get the best care for themselves, but emotionally, I think they have higher levels of distress. They're kind of white knuckling treatment and white knuckling having their doctor as their doctor. The research also shows that individuals who have healthy and a lot of social support seem to do well with poor social support. Again, compliance, they might not go to their appointment. Poor social support, they might be too depressed. They might not eat well. They might not be sleeping. They're depressed. No one's helping them. No one's calling on them. And it doesn't go as well. And then another psychosocial issue is, I think if someone doesn't have the skills of decision making, and this is a hard one because if you don't have much experience or knowledge in the medical healthcare system, and then all of a sudden you have this significant diagnosis and life-threatening potentially, it's scary, it's a lot of information, it's hard to make a good decision. And actually that's what I do a lot with clients is help them think through decision making in terms of treatments or treatment providers.
That's great. I think you did such a great job of explaining some of these psychosocial issues that cancer patients have in particular. You know, you had mentioned that you see a lot of breast cancer patients and survivors. I was curious about what are some of the presenting issues specific to breast cancer?
Again, it's varied with age, with relationship status, and with type of cancer, type of breast cancer. Your listeners may be familiar with the different types of breast cancer and the stages, and some may be more aggressive, some may be very, very early stage, and that then leads to the type of treatment. So some may have more aggressive treatment, some may just have a lumpectomy or mastectomy and no other treatment. Some people may have chemotherapy, radiation, and surgery, or any variation of that. Some may have hormone treatment, which comes with its side effects. Some may not. So the issues are varied depending on all those factors. But common presenting issues specifically to breast cancer, I think obviously would be body image concerns, hair loss, and reconstruction if they will be having a mastectomy or a bilateral mastectomy or even lumpectomy. But over the years, the 22, 23 years I've been working in the field, The reconstructive surgeons they just keep coming up with more and more types of surgery for better outcomes for women. So it's really exciting. So body image, some of them feel like their breasts, if they have implants, are not their own. They don't feel like it's part of their body. So that affects how they feel about themselves sexually. It feels differently. And usually the partners are supportive. Maybe occasionally we might have a partner that's unhappy with the changes. Yes, so then we try to work together. But mostly the partners that I've worked with are pretty supportive regarding the body image for them. The other big issue is kind of what I was talking about before with some of these younger, successful, driven, intelligent women is balancing everything. They're balancing work, they're balancing parenting, they're balancing family, they're balancing marriage, they're balancing caring for themselves, having their own friends, if they have hobbies and interests. It's very, very difficult. Very difficult. I would say at this point in the past 10 years, that's the number one issue, is doing it all. The sexual issues can become problematic, especially if their breast cancer is hormone receptor positive. And so they are taking medication to prevent future recurrences by suppressing hormone production. And so you have very low sex drive, painful intercourse, there's atrophy of the tissues. A lot of cancer patients who have chemotherapy or radiation or post-surgery have fatigue, which plays a role into sexual issues. So that's a big one for breast cancer because of the hormones or the lack of. And then I think those are the specific to breast cancer. Then you get the usual kind of anxiety, fear of future. Some clients come in and share with me that they're private and they don't want anybody to know. So they don't tell anybody except their spouse or partner and employer. And I will tell you, I don't recommend that. And because every client that I've worked with that doesn't want to tell anybody, I find that they're more at risk for depression. And it's very stressful to keep a secret. It's hard to keep this a secret. And so it takes a while. Eventually, they find that they can share with people and they could receive supportive responses, and it's all okay.
It sounds as though that there's a lot of expectations that you're voicing here, or rather your patients are voicing of wanting to then continue to achieve and perhaps even produce at a high level. And oftentimes that can be problematic. You also mentioned that there's sexuality and intimacy issues, specifically that are common for this population. And I was wondering if you could just tell us more about that. You brought up a couple, perhaps, difficulties, and I was curious if that's something you could just speak more to.
When a breast cancer patient or survivor presents with that, I usually first start to explore with her about what the issues are. And again, the history counts here. Prior to cancer counts. If they have a history of sexual trauma, that's going to play a role, even usually exacerbate the sexuality issues post-cancer. So we have to look at the history, their sexual history. And after we explore that, we can identify, I ask them what their goals are in terms of the sexuality issues. And then if they have a partner or spouse, we bring that person in and start with communication both ways, which is mostly listening. Is the skill to teach is listening, not speaking, and helping the couple listen to each other. And it's interesting because usually they both have the same goal, and we just have to figure out a way to help them work. The three of us work together to help them reach their goal. And it's usually just communication. I wish you would touch me like this, or ask me, or not ask me, or not touch me this way or that way. And so both need to express what they need, how they feel. And it's really a negotiation. I think marriage and relationships aren't a bunch of negotiating anyway. And then usually if it's a heterosexual couple, the husbands, I tell them, I joke with them, I said, if you just listen to me and your wife, trust me, you will get your needs met. And it usually is fine. And so we work it out, the three of us, that way. Now with the patients, the clients who are single, dating comes up. And the first question is, do I tell someone I'm dating I have or had cancer? And so it takes a while to kind of look at that, depending on the date, the type of date, have they met in person? Everybody's on apps. So it's a whole new dating world. And I find that the women do fine with dating. And again, it just comes back to communication and listening. And if you're dating someone who doesn't want to listen or doesn't care about what your needs are, then it's an easy answer for you to know not to date that person.
Yeah, run for the hills at that point, right?
That's right. And so it's kind of nice, I think, sometimes with cancer, if you bring it up at an appropriate time when you're comfortable bringing it up, the response of whoever you're dating is going to tell you a lot. It's going to tell you a lot. And so having had cancer and dating might actually make it easier to find the right person.
I could share a personal story on that. I mean, in one of my first dates, I laid out my 5-year plan. And I think that was specifically because I'm like, I'm not going to mess around. I'm like, it's a different perspective in that sense. Now, in speaking to the perhaps support here, you had mentioned that communication is really key here with having loved ones support someone who's going through a cancer process. I was curious if there's a way that can be expanded. If you can tell us a little bit about how others in the family or friends, colleagues, whatever that might be, just sort of expanding it. How someone can best support someone through the cancer process.
Right. It's difficult, I think, for friends and loved ones and colleagues to know what to say and what to do. And I've had friends and colleagues and neighbors have cancer. And even though I do this every day and I'm very comfortable, I always, it's a little hesitant because you don't know exactly what they need. So I think one of the best things is to ask. Oh, I am calling you up to see how you're doing. I know you're going through chemotherapy. Is there anything I can do? They usually say no, because I have to teach my clients how to ask for what they need. They don't want to ask people because they don't want to burden. So I'll work with that side. But if they say, oh, no, I'm fine, sometimes the small things like finding them someone to help clean their house, finding rides if they have children to school or to extracurriculars or to birthday parties. So you could offer that to, of course, food. The problem with the food is everybody jumps in with the food. And my clients tell me then they have too much food and it goes to waste and it's just too much and they don't have the refrigerator space. So if you want to provide meals, there needs to be some calendar or someone needs to be in charge to make sure the family doesn't have too much food.
Yeah, there's like a meal train.
Meal train.
Yeah.
Right. So I think just to ask, and it depends. If it's someone who's just an acquaintance, so there was a parent of a friend of my daughter's that I didn't know well, but my daughter told me that she was going through breast cancer treatment. So I didn't know her that well, but I knew her enough and we'd see each other. And so I just went up to her and I said, oh, my daughter said you were going for treatment for cancer. How's it going? How are you doing? How are you feeling? And I know enough and I'm in the community that I could say, oh, where are you being treated and things like that. And hopefully one could pick up if they want to talk or not. And if someone doesn't want to talk, then just say, I'm thinking about you. I'll be thinking about you. And then every so often, send a text, leave a voicemail, send a card in the regular mail, thinking of you, brighten your day, something like that, instead of asking any questions or offering anything. And I do that now when I have friends that are, unfortunately, my cohort, their parents are starting to pass away. We're of that age, a lot of us. And so I'll just send texts randomly, say, just thinking of you. Hope you're having a good morning. So I think that's the best way.
I like that. I think that's an artful way of showing your support without being pushy or asking if they need something, because they can be repetitive or maybe even unwanted.
Yeah, it may be unwanted. I think what not to say, if I may, I mean,
please. Yeah.
Well, I am going off of what my clients who are cancer patients and survivors tell me they don't like, which is, oh, you're so strong, you're going to be fine. Or when treatment is over and everybody wants to celebrate, at least the breast cancer clients the clients with breast cancer, many times will tell me, yes, I rang the bell when they finished with my treatment, but I don't feel excited. I don't feel like celebrating. There's many reasons for that. One of the reasons is for these breast cancer folks, it's not over. There's usually more treatment ahead with the hormone suppression or immunotherapy or reconstruction. I mean, it just goes on and on. So don't tell anybody they're going to be okay, that it'll all be okay. Or when they're done with treatment, oh, you're done. You don't have to worry about it anymore. Well, I could tell you as a psychologist, even if someone reaches remission and no evidence of disease, and even if they've been cancer-free for 3 years or 5 years, many people still worry about it. So those are things I wouldn't say. Or don't tell them about a friend or loved one that died of cancer. That's not good either.
Yeah, I recall during my experiences that I had, like, my brother asked, like, has your brother died yet? Like,
oh my.
And yeah, that's not the best thing to say. And I had that same personal experience where I had come home after my initial chemotherapy and hospitalization prior to my bone marrow transplant, and the support just kind of fell off after. Like, okay, you're home, so everything's different now, and you're good. But that wasn't the case at all. So that is a very helpful point to bring up, because it is so much of an adjustment. And like you said, to maybe circle it back, dealing with this is a lot of the theme of loss and change, or perhaps even dealing with the new normal, having to have that opportunity to look at how your life is now that you've had this cancer experience.
Yes. And I would think with bone marrow stem cell transplant, most people don't understand it at all. And so I would imagine that may be even more difficult. They just don't. I find that a lot of people didn't really understand it. That was hard to understand, as opposed to a solid tumor, breast cancer, or colon cancer.
Right. I think the common misconception there is a bone marrow transplant is a surgery. And it's not exactly that. I mean, for me, it was, high dose radiation to bring the bone marrow, or to kill off all the remaining bone marrow. And then the process of just having an IV with the new bone marrow from my sister that was, a match. And that was the process. But it's then making sure that it's actually taking, and that there isn't any issues with a complications such as graft versus host disease. But
and that could be chronic, so it's not over. As some of my clients, a lot of them talk about, and these are these women with breast cancer. Sometimes they're quite funny, but many of them have said, and don't even know each other, they just say the same thing: the gift that keeps on giving. And they kind of laugh. Is sometimes just constant. And with bone marrow stem cell transplants, if you have graft versus host, or it becomes chronic, it's not over. So
there's plenty of those late effects that I know that Dustin and I have come across since our treatment, and it is that it is that gift that keeps on giving. That there's just it's kind of always things to be aware of, or perhaps diligent in making sure that you're on top of your medical care, your personal health. That is.
Yes. Yeah. And sometimes the psychological issues that came up because of a cancer diagnosis don't get addressed for many reasons. But, I've had some individuals say in the oncology office, oh, well, this patient was crying, or they're anxious, but of course they're anxious, or of course they're upset. They have a cancer diagnosis, meaning it's, quote, normal or common to cry when you're given a diagnosis. So because it's so common, we don't need to do anything about it because it makes sense. And they don't refer patients for maybe a screening by a social worker or referral to a therapist or psychologist because, of course, you're upset or anxious or sad. And for some of the patients, I'll get calls, oh, my oncologist gave me your name a year ago. I get this a lot. A year ago. And finally, here they are 6 months ago.
Oh, wow.
There's still stigma around mental health. I think it's getting less and less. But back in the 70s, when the field started, there were two stigmas. There was a cancer stigma for many, many decades. Cancer was a bad word, and you whisper it prior to the 70s. And cancer became less stigmatized. But then now we have mental health, the stigma of that. And so it was a hard start. But I have to say, even since I've been in the field, since the late 90s, we've come a long way to have distress screening and cancer programs and cancer centers. I think in the past, I don't know, what would you say, 5 to 7 years, mental health is more in the mainstream, would you say? Talking about mental health? So that's good.
Yeah, I definitely agree with that. I think that there's just been kind of a shift to having that recognized as a piece of that overall health.
Yes. So we're moving in the right direction.
Well, I wanted to thank you so much for being with us today and sharing your expertise.
Sorry for being so quiet. This is just a very fascinating conversation. Just talking to Colin prior to this, and probably edit out some of what I'm saying, is I've got a really bad cold. So,
I'm so sorry.
Yeah, so I'm like holding in the coughs.
He's a trooper.
I'm holding in the coughs whenever I talk. But yeah, no, it's definitely a very interesting dialogue, and I could relate on a lot of levels with all the side effects that you have and stem cell stuff. It's pretty big. My stem cells were my own, so it's slightly different, but I did some pretty intensive chemo. So
yeah,
I feel like everything was really good.
All right.
Thank you for being on our show.
Oh, my pleasure. I hope, a lot of people listen and are able to get some help and comfort or find that mental health provider in their community to talk to.
All right. Thank you so much.
Our podcast will discuss topics related to cancer treatment and the recovery process, including diagnosis, family support, resources, medications, and nutrition. We aspire to have conversations pertinent and relevant to the cancer journey.
Thank you for listening to the Sick and Good podcast. We'd like to invite you to connect with us on our social media and Instagram and Facebook accounts. We're also happy to share that we have launched the Sick and Good podcast website, sickandgood.com. This website is a place to read our bios, subscribe to the podcast, listen to full episodes, or read full transcripts, and contact us with your questions or comments. We care about your listener experience and would love to hear from you to keep the conversation going on the topics of cancer and wellness.